This conference will now be recorded.
Hi, everyone. This is the high-risk, recurrent, and advanced prostate cancer group for AnCan. I'm Len Sierra. It's February 15, and we're going to start tonight with a new member, Kevin Bagnasco. So, Kevin, can you tell us how old you are?
Sure, I'm 64 years old. And somewhat ironically, I think it was this week that I was diagnosed with prostate cancer. I had my biopsy, and I was diagnosed with prostate cancer kind of like this week. I had the biopsy confirmed that there were numerous, cancer cells. I had a Gleason score of 9. Immediately, we went to see, the top surgeon at Sloan Kettering. We didn't want to deal with anything over in Long Island, so it was either going to be, it was really going to be Memorial. So Dr. Langone, he performed a radical prostatectomy on me in March. 1, 2, 3 right away. They got me in. He took out 15 lymph nodes. He took my prostate out, my seminal vesicles. He scraped my bladder, which was somewhat cancerous. And of the 15 lymph nodes, 12 of them were cancerous, showing signs of 7 to 9 Gleason scores. So he told me that like 2 days after the operation. I remember I was in my car. I felt like I had a ton of bricks hit me in the stomach. The surgery was performed so well. And when you go over to Memorial, they put you in the VIP rooms. You're in there for a while, and you're out the next day. Well, then, sure enough, a day or two later, he said it's in my system. Well, we knew it had spread because I had some lymph nodes in the common aorta iliac that were like 2 centimeters. They were large. So in any event, I had to look for an oncologist. I went to Sloan's oncologist, and I didn't relate to him at all. So he told me that I had 2 to 3 years to live. He said I should gamble with this one very aggressive trial, which I was all set to kind of do. But I ended up doing some more due diligence. Like I opened up to a lot of different people. My medical information went to the Mayo Clinic, Johns Hopkins, Dana-Farber. I went to see Petrolak, who's like a rock star up in Yale. And I ended up over with Scott Tagawa over at Weill Cornell. And I don't regret that decision at all, especially, he has my best interest at heart. I relate to him. I relate to his personality. So in the beginning, we had, was it Decralex, I guess, the shots in the stomach?
Degaralex.
Deralex, yeah. Then after Deralex, we had the shots in the stomach for maybe 6 to 9 months. He said to me we could just do the Lupron. So we did the Lupron for a number of years. Within that time, I did have Provenge. So they did the Provenge.
Hey, Kevin, let me interrupt for a moment because somehow I got some bad information. Tell me again when you were first diagnosed.
February of 2015.
2015, okay.
Yes. And you want to ask me questions?
And were you a 5 plus 4 or a 4 plus 5?
I think I was a 4 plus 5.
Okay.
And, I'd have to review my notes. Can you tell me what the difference was or is?
Well, the difference is whether you had more 5 than 4 or more 4 than 5. And the place you'd find that definitively would be in the pathology that came from your surgery.
All I know is I was given 2 to 3 years.
Who told you that?
That's a whole nother problem we can get into.
That guy was, he was such an ass.
So much for prognosis, right?
I know.
Yeah, so much.
He was
I mean,
such an ass.
Kevin,
Guys,
we could
do one at a time, please. Kevin, who was it that told you that at MSK?
Oh, what was his name? Dr. It similar to DeCola, DeVita, I don't recall. Mind you, I had
think it was
chemo
my
today.
guy.
I'm not on that.
It's your guy, Len.
My
It's your
guy.
guy.
Oh, great.
Danilo.
Sorry. I
Danila.
just didn't realize it.
Danilo, isn't it?
Is it what?
Danilo.
Danila.
Danila. Yeah, he's Romanian.
Yeah. He's. I left him too. That was a good move on your part. And you know
Yeah,
what? I remember when I was diagnosed, I said, "How much time have I got?" Not knowing much at all about prostate cancer, and I said a year, 2 years, because he said I was stage 4. So he goes, "Well, I don't know yet. We'll have to see how you respond to therapy." So, right away I'm thinking, oh, I guess 1 or 2 years is, that's within the realm of possibility. But anyway, here I am 7 years later. So go ahead, Kevin.
That's great. And I didn't connect with him. So, but with Tagawa, I connected with him, and we went the course. So I did the shots. I did the Provenge.
So Kevin,
Once
what was
yes,
your PSA at diagnosis?
at diagnosis it was 9.
And
No,
then,
excuse me. At diagnosis it was 5.3.
Uh-huh.
and then
Five.
what happened after? And then what happened after surgery?
Well, at surgery, that's the thing that they were testing me again like in June, the beginning of May, and I think that was too early. It was down to a 1.2 maybe or thereabouts, but it was ticking up. So it was ticking up, and then I went to see a radiologist. And the radiologist at Memorial in Comac said, you can't do radiation because it's systemic. So that's when I went on my journey to just speak to a lot of people and send out all my information, to the Mayo Clinic, to Dana-Farber, to all of those hospitals. And then I ended up deciding to go with Tagawa because I thought Petrolax, he's a very fine doctor and everything, but he's got a very large ego, and I don't think I was going to, connect with him. So afterwards we did, it seems like Scott Tagawa has put me through a lot of different things.
So what did you start with after when your PSA started to go up?
All right, then we ended up doing the, after the Provenge, we did the lutetium 170.
So you did Provenge when?
I did Provenge about 5 years ago.
Okay.
But he just basically Dr. Tagawa felt Provenge really doesn't do much, so he wants the targeted radiation. So we did Lupron 177. He got me into a trial with Lupron 177.
Lutetium.
Lutetium 177. Right. Lutetium 177. We only had one injection. So after that, my PSA went down a lot. It came down from kind of like a 4, and then it ticked down to like right around a 2. So it was going pretty well, and that was for a couple of years, and then it was increasing. We did, I guess, the Zytiga. He put me on Zytiga, but it didn't really react too well. So it was like I was told you either go big or go home. So with that, we ended up going home. And after that, I ended up going on to the same trial that Carl was on. That's how I met Carl, that PSMA trial with, the radiation and the alpha. Yeah. with the
Immunotherapy.
alpha. So that's where it's leading me. So then with that, we were on that for what, about 4 months, Carl, or thereabouts.
24 weeks.
24 weeks, yeah. So that was like 5 months, almost 6 months, and now I ended up I'm on my second dose of chemo, which I took today, and I found that the chemo is I'm taking docetaxel, and it's working well. It's fantastic. I'm in no pain. My cancer has spread to my bone skeleton organ, and that's it. It has spread to my skull, my cheeks, in my spine. I've got it on my number 1 and number 2 membrane there. It's in my hips. It's in my femur. It's in my ribs.
So before chemo, what was your PSA?
Before chemo, let's see, it was doubling. It was the rate of increase. It was kind of like doubling 50% each month.
What was the number, Kevin? What was the number?
Before chemo, the first start of chemo, it was 19.
19. Okay.
Yeah.
So, I tell you what fascinates me with a diagnosis like yours, and you're down to 16 now, which is good.
No, it was. Hold on a second. It was 16. It dropped to 12 3 weeks ago after that first. Now it's up to 19 today.
Okay. So it went from 16 to 12 to 19.
Correct.
So what fascinates me is that you've got some good names in there, but for I don't want to say for the longest time, for the last 4 years, maybe 5 years, we've known that the way to treat multi focal metastatic cancer is with chemotherapy. That's sort of been proven, and it amazes me that some of these docs are using trials before multifocal, before chemotherapy. You have an unusual type of cancer. We could tell that from you telling us that you were a Gleason 4+5 with a PSA of 4 or 5, because we've got 2 or 3 other guys, several other guys, Herb and Ben and Ken and Steve Saft, who isn't on today, and others. And when you see that 9 or 10 with a low PSA, it's a huge red flag.
Right.
That cancer is probably not going to behave the way you'd like it to behave. And when you defer chemo, my own personal opinion, I'm not a doc, but what I've seen is it doesn't make sense to defer chemo with people like that. And so I'm just making an anecdotal point. I'd be very interested to hear what, especially somebody like Herb, has to say on that.
Well, I guess what I have to say is it seems like you had a very unusual series of therapies, Kevin. The normal guidelines for treating metastatic prostate cancer would start with chemo or Zytiga, for example, and then move on. We don't know whether you were ever castrate sensitive or not. There were these 2 phases of prostate cancer. Did Dr. Tagawa talk to you about castrate sensitivity versus resistance?
I think we did go over that.
I think he tried to do that, it wasn't working, so he's probably castrate resistant.
Well, but I'm thinking
I'm totally castration resistant. Yeah.
right now you are, but the question was, were you ever hormone sensitive? It's impossible to go back and say, But but you're getting chemo now, and the question really is, for me, you've had pulsatile, and it dropped your PSA sorta. So, and are you getting that is Tagawa giving you the docetaxel?
Yes, yes.
So, given that your PSA went up, what did he tell you?
The same old story. It's like they're not worried too much about the PSA. It's, and maybe that we're taking tests so frequently that, perhaps we didn't get a correct reading.
So you only had one dose of docetaxel, right?
I've had 2. Today was my second.
Oh, okay, right,
My first one was 3 weeks ago.
right. Okay.
And you're scheduled for 6?
No, I'm scheduled for as many as I could handle. That's what his comment was.
Did you have
Once
any
every-
tests?
Can I come in for a sec, Len?
Go ahead.
When was the last time that you did somatic sequencing of your tumor?
That must have been 7 months ago, and I need to send that over to Dr. Wyse in Langone. I did
Okay.
try to. I spoke to. He's another nice guy. I tell you, he called me right up,
Okay.
David Wyse.
Hold on a second, Kevin. Let's just stick
Sure.
on this. Now, did that 7 months ago when you was that a liquid biopsy, or was it a solid tumor sample that you gave them?
It was a solid tumor. It was in a bone. That's where my tumors were.
Right,
So-
and they
so-
took it from the bone at that time.
That's correct.
Right. And did it show any mutations?
Yes, it did.
What did it show?
Well, you guys are really into this. I'm sorry. I don't analyze this as much as I should. I can't answer that question,
Okay, so I'm asking you for a reason.
because I rely on my doctors. But
Yeah.
but
But sometimes you have to. What you'll learn in this group is that sometimes you have to do some of your own work so you can challenge your doctors, and that's where
Yes,
I'm leading with this. I'm not trying. Believe me, I'm not trying to show you up or what have you. We're trying
You're
to
not.
get a
You're
hook.
not.
We're trying to get a hook here, and let me tell you where I'm going with this hook. Your disease is weird disease. Weird disease sometimes requires more than docetaxel. Now, what we're trying to find out, and what we'd like to know, is was there anything in that last somatic test that you did that might indicate that right now adding another type of chemotherapy to the docetaxel would make sense? And sometimes the don't do it.
Yeah. I questioned Dr. Tagawa on that today, and I asked him, why don't we, give it with a 1-2 punch? And he said that there has not been any proof that 2 chemos work better than 1.
Yeah, that's not true. I can tell Dr. Tagawa, I can point Dr. Tagawa to trials and papers. And so
Right.
I don't buy that. I mean, we have papers out of MD Anderson, led by Paul Korn, and Elena Efstathiou, that show that it does make a difference. So the question I have, and we can give you that to show him, but the first thing we need to do is to see that somatic test. Who did you do that test? When you did that somatic test 7 months ago, do you recall who it was sent to?
Tagawa.
Yeah. Do you recall who Tagawa ordered it? Who did the analysis? What lab did the analysis?
I don't know that.
Okay, so what you need to do is ask Dr. Tagawa for a copy of your somatic testing from 7 months ago. Really, really important. Carl Forman will coach you on this. He knows how important this is. And you can talk to Carl afterwards, but you have to get from Tagawa a copy of your somatic testing. And we have to take a look and see what showed up. Tagawa may be 1,000% correct here. The problem is you don't know, we don't know. It's so important to get copies of all of this. I know that there is there's an ethos that our doctors know best, and we put our doctors up on the table on a pedestal, and we kowtow to them. But we
Yeah,
don't
no,
buy. We
that's
don't
why I
buy
was speaking.
them.
Yeah, that's why I was speaking to Dr. Wyse.
Okay, well,
I went-
again,
yeah.
you haven't mentioned that, and we can send you for people. I don't know who it is that you're seeing for a second opinion, and we can certainly talk about that. But what I do want to say to you, and actually I'd rather that some of the other guys said it, because I feel it's stronger when guys that we've navigated walk in and say, yeah, we challenged our doctor and this is what happened. And I mean, David Muslin, just give a testimony as to what happens when you challenge your doctor.
Well, I challenged a very high profile doctor in Chicago, and she shut me down. Wouldn't hear it.
And then
I went to another doctor at University of Chicago, also very well respected guy, and he welcomed me in, and he was happy to listen to anything and happy to try anything that made sense. And we bounced a few ideas off of each other, and off I went.
And what made you switch doctors?
I didn't have the rapport with the first doc, and I ended up with a great rapport with the second doc. But specifically because I wanted to go on a certain drug that I challenged her on, that I learned about here at AnCan, and she wouldn't hear of it until a year and a half later.
Right. And
finally she came around.
Would you say this group had anything to do with you making that change?
I'd say this group had everything to do with me making that change.
I'm sorry to lead you, but that's what I'm
That's
trying
okay.
Look, I don't know Dr. Wyse at NYU Langone. I would say that there are a number of terrific GU medical oncologists in the New York area. I don't even know if Dr. Wyse is a genitourinary medical oncologist. I've never run across the name, man or woman. Maybe, may not be. It's not who we would send you to for a second opinion, but they may be very good. But if you're looking for second opinions outside of Weill Cornell, we can help you with that.
All right, that'd be great.
Well, Kevin, I thought you said you sent your material to a lot of different places.
I did send my material to a lot of different places back when I first.
Therefore, you must have had some contact with GU oncologists there.
Yes, but my contacts were at Dana-Farber, Johns Hopkins. I never spoke to anybody over at NYU. And it was Memorial.
What did the guys at Dana-Farber tell you?
It was just everything was the same protocol. Just go with the anti-testosterone, the testosterone blocker. It was the same sort of thing. Everybody seemed to be on the same page, and I wasn't going to go up to Boston or to Baltimore. I don't even know if my coverage would have, my medical coverage would have covered it. So, yeah, it was early on. It was early on in the game.
Early on. So, Kevin,
yeah.
You know what I would do, since you liked him and he's really good? I'd get a second opinion from Petrolac. I'd go to Petrolac.
Would you?
That's where I go. I wouldn't mess around with anybody. Hey, Herb, you're our main man. Who's Dr. Wyse? Can you tell us who Dr. Wyse
I
is?
can't, I'd have to know his first name or her first
David.
name.
David.
I will know soon enough.
It's W-Y-S-E. Herb, W-Y-S-E. So, I would go to Petrolac. He's a very good guy. He's a great name. I know you didn't relate to him, but John Antonucci, who's on the call right now, seems to do well with him. And he'd be a great person for a second opinion. And you know him.
I think you're right. Yeah. I think you're right because he really knew his stuff. He was good. And he works, although it's at a New Haven, he's got an office in Greenwich. So, and he might be working out of another hospital, near Greenwich too.
That's, if it were me, I think that's where I'd be heading. I'd be heading right now. And I think it's really, really critical that you get hold of that report from 7 months ago, because that's going to tell you an awful lot.
I have that report.
It's
Yeah.
it's WISE.
W-Y.
Yes, correct.
ISC, and he's a urinary medical oncologist at Ladome.
Yes.
Okay. Sorry, it's an I. My source of information just corrected himself.
I ended up getting that name from Jamie over at Zero Prostate.
Kevin, are you familiar with the Weill Cornell portal? Have you ever used it?
Yes, I have.
Okay, so that's where you can get your pathology report, your I think maybe your genetic screening, your somatic mutation test. I'm not sure. Sometimes they'll post it.
Yeah, I tried to look for it. It's very difficult. So I ended up just getting a copy from the nurses.
From what you said early on, it sounded like you're from Long Island.
Yes, I am.
Whereabouts?
I live in Long Beach.
Yep. Okay. All right. So do you have any specific questions for us that we haven't already addressed?
I think that I'd like to know what sort of things I could do to help the chemo. Is it with, eating properly and, kind of like taking ginger or any of that? Do you have any literature on? Someone was telling me that it was like in the morning they would take lemon, ginger, cinnamon, apple cider vinegar.
You have very aggressive disease, as I do, as a lot of us here do. Diet is
lemon's not going to cut it.
Diet is not going to make a big difference. And however, having said that, you should probably get a copy of the Prostate Cancer Foundation's, I think it's called Living Well with Prostate Cancer. It has a lot of dietary information there, and you can trust them.
Okay.
We can't go into individual analysis here of what's good.
No, yeah.
Okay.
Now you're very, very helpful.
Just a couple of things. The first is that the sort of things that you're talking about are specifics. So if you're experiencing nausea, for example, that may well be. If they should have given you an antiemetic to help you with nausea, yeah, but certainly things like ginger are very, very helpful for nausea, and there are other natural. I'd also like to throw it open to all the other guys who have done chemo here for their suggestions. One thing we can tell you is that you should be doing your very best to exercise every day, because that will certainly help. It will make the chemo more efficient, and it will help you reduce your side effects from the chemo. So we haven't talked about exercise. We don't really have time to now. Next week, maybe we will. But that is so, so important.
So
Anybody else have?
don't
Yeah,
be
go ahead,
fooled
Debbie.
by the fact that you're doing okay for number 1 and 2. Probably by 4 you'll start feeling it. And
Oh,
diet,
really? Yeah.
diet, you're going to I wouldn't make too many changes because you're not going to feel like eating much at all, and everything's going to taste like barbecued aluminum foil. So
You know,
just
yeah.
be ready. Be
The
ready
big,
for the ride. You'll make it through. You'll be okay, and you'll find your
yeah.
own rhythm. And since it's open ended, you've got to find your own pace with this. And
Right.
just ride it out. You'll feel pretty crummy for a few days, then it'll come back.
Guys,
Okay.
it's 40 minutes in. We need to move on to our next new.
I just want to say thank you.
Okay, Kevin, thank you.
Thank you very much.
And we'll see you next week, hopefully.
Yes.
Okay, so Larry Meadows, are you ready, sir? Is Larry still with us? There he is. Yes. I can't say something, Larry. Let me make sure we can hear you. Oh, we cannot hear you, even though it says your mic is on. I think we were able to hear you before.
And I have to say, Len, I think Larry's been with us before because I have extensive notes on him and I remember the name.
Oh, he told me.
I know he did, but we recommended him to go see Bryce or Singh. Now, it may have been a conversation. Larry, did you and I just speak offline? We may have done that, but I have extensive notes on you and I recognized your name. I remember you. You got a C11 from Almeida and goodness knows what. Are you with us?
He's got an audio problem. His mic is on, but we can't hear anything.
Larry, why don't you go out and come back in again?
Yeah, try that, Larry. Log out, log back in, okay? We'll catch you later. We wait or move on? Well, let's see if we can squeeze in somebody while we're waiting. Let's see, how about you, Bill Bradford? You said you wanted time.
Yeah, just a quick update. So I think it was last week, I had given an update that I had received some SBRT to my single bone met up at Mayo. They were recommending that I then come off the ADT after I've been on it for 6 months for my oligometastatic disease. MD Anderson was saying now you should stick on it for at least a year. Rick had challenged, just saying, you know, in his experience, if you stay on for, you know, a year and a half, you probably have better chances of staying off ADT and maybe not having a recurrence. He recommended I have a consultation with Dr.E, Estathio, if I can pronounce that right. And I did, and she is amazing. I was getting pulled in different directions. I think I had some weak doctors at MD Anderson. Mayo clearly was, you know, telling me something different. But boy, I had a consultation with her last week, and I mean, she was everything I was looking for. Very aggressive, very assertive. Bottom line, you know, she was appalled that I hadn't yet had genetic testing done. She's like, before you leave, I'm getting your blood. We're doing genetic testing. But she did agree. She's like, you know what, at this point, you've already stopped the Zytiga. She said, you know what, I do want you to come off the thing. And she said, I don't even like the scan that MD Anderson gave you, the Examen. She said, we're going to just monitor you, active surveillance. We're going to see what the genetic tests tell us. And if your PSA comes back and you have a recurrence, she said, I want you to do the PSMA. Regardless if insurance is going to cover it, we'll push for it, but it's money well spent. So she just, I think Ricky said it sounds like you need a quarterback, and that's it. I've got it. So I think I'm fortunate to be seeing Dr.E now at Houston Methodist.
Yeah, and I mean, we'll certainly defer to her since you've stopped already. She has her reasons, but I have a feeling I know what those reasons might be. She's probably thinking, let your PSA rise a little bit so that we can see where the cancer is.
Yeah.
What's your PSA right now?
Undetectable. You know, my testosterone is still undetectable because I'm still in the 6th month of ADT, and I had a 6-month injection, which is supposed to expire in March, but she said, no, don't go for another injection. She said it's going to be summertime till your testosterone maybe is back. So,
Yeah, I mean, given that she's already talking to you about a PSMA, my guess is she wants to know where that cancer is. So she says, come off right now and we'll figure out where the cancer is and then we'll go from there. But I'm just delighted. I mean, you know, she keeps hitting these home runs with people that are in this group, and that's because she's great. I mean,
yeah,
she's on
she
the ball.
she spent 1 hour with me and asked me questions that nobody has asked me, and just really take charge. It was like I loved it. So I appreciate the referral.
Pleasure.
And just, I guess my story adds to what we were talking about before. If you know if you don't like a relationship with a particular doctor, which I really did not like at MD Anderson, my radiology oncologist, which made me go up to Mayo to get SBRT, you got to take matters into your own hands. And yeah, I feel like I'm in a good place now with Dr.E. So.
Couple of quick questions. Who was the rad onc at MD Anderson you did not relate to?
Yeah, Dr. Chun, CHUN.
Okay. I mean, it's just helpful for us because we like to base our recommendations on what other guys have done. So we just keep that in mind. And secondly, did you mention to her that you found her through us?
I did indeed. I said, I was getting pulled in different directions, and in my AnCan support group, specifically Rick, told me that I might want to look you up. And yeah, I dropped your name.
Okay. All right. Anyone else have anything for Bill?
All righty. We're going to go with Chick Lindsay. You're one of the first ones on after me. Chick, it's your turn. You're muted. There you go.
I'm trying to. Okay. How about now? Can you hear me now?
Yes, sir.
Okay. Thanks. Just need a quick check-in. I'm at a place now where I'm trying to find the radiation oncology services. I just started on Eligard last week, and one location I'm looking at is in Minneapolis at the University of Minnesota, and the logistics there are a little tougher for me. And I also have an appointment. I actually don't have the appointment yet, but soon we'll be checking in with a Mayo Clinic affiliate in Western Wisconsin, the city of Eau Claire. They have a small cancer, described as a cancer center there. Anyway, my question is does anybody have any ideas on how to, quality control? How do I evaluate, the services that I'm going to receive? I'm assuming it's going to be something like 30. University of Minnesota is already recommending 33 radiation treatments. So I guess but I don't know about Eau Claire. I assume it would be the same. The radiation oncologist at the University of Minnesota, actually was the one who said, you might want to consider finding a place that can do the radiation closer to your home. And my wife and I kind of thought that would be a little bit easier to do, and a lot easier to do actually. But I still don't rule out the University of Minnesota if I had a reason. I saw some red flags with Mayo Eau Claire. So anybody have any ideas on how to evaluate? I saw a piece of paper that's got some questions asked, but the oncologist. But
Well, Rick, I guess you're the one who knows everybody everywhere. You want to handle that?
Well, I don't really want to. I don't really want to talk about specifics in eastern Wisconsin because I'm not that. I don't know that well. What I'd like the group to talk about is how do you evaluate a good RO? How do you decide whether a radiation oncologist knows his stuff or doesn't know his stuff? And I have a bunch of ideas, but I'd really like to hear from the group what they've got to say on this. Anybody want to kick that off on how to decide where to go for your radiation radiation?
I can
Check,
go along
check
with
this,
your recommendations.
check this is Peter. Just regarding the actual therapy, you won't feel much. You can travel, you can drive yourself there and drive yourself back and drive for 45 minutes, an hour. You might have to bring a bottle in case you have to pee in it or something like that. But generally, you're not going to feel much different. You'll be okay, no matter where you do it.
okay, that's I appreciate that comment. That's helpful. Yeah, I think a lot of fear around how the cumulative visits what might impact my
So,
emotions, that kind of stuff. But that's good to know.
I mean,
I guess it's more like. Sorry. Go ahead.
You'll have a little
Price,
bit.
I was just going to say that it's kind of like a surgeon. That how many times have they designed, this for somebody with a similar characteristics as your prostate cancer? So, is this a guy that's done it 10 times or 1,000 times?
Yeah. Okay.
I totally agree with Don on that. And he, not only that, but radiologists generally are introverts. That's why they're radiologists. They don't like to interact with people. So if you find one that's very outgoing, it would be a good idea on top of what Don said. It is very important, the number that they do. And all I would say, knowing where you are and you can get local help and good local help, except when it comes to radiology. So a trip to Mayo or a trip to the university is worth it for the imaging side of your.
yeah, but Jerry, but
process.
this is not imaging. It's really radiation oncology, which is the use of radioactivity. And the question is, how good? I mean, it's a base to me. It's both the person and their equipment when it comes to radiation oncology.
And I agree with you on that. And you definitely, if you know equipment, you need to know what it is and how long they've had it. And you're not talking about inexpensive Varian, if you will, different type of equipment. Varian's one of the biggest equipment manufacturers for radiology oncology. But it goes right back to what Don said. I don't care. The radiology oncologist has to be busy, has to be doing a lot of volume, not one or two a day.
I think there's more to it than that, Jerry. I think that in this day and age, it's really important to know how they're going to guide the radiation. What different equipment guides in different ways, and newer equipment guides better than older equipment. So one of the questions that I would be having for them is whether they're using the most up-to-date equipment, where they're basically using the equivalent of a CT scan to calibrate the machine before every before every session, which some of the machines now do, or are they using fiducial markers, or are they using transponders? When did they get the equipment? How long have they had the equipment? And how are they going to guide it? And then you can come back and talk to us here. But the technology is moving very quickly. And I mean, what I did 10 years ago, I wouldn't do now.
That's absolutely right, Rick. So there's
Hey,
nothing wrong with.
Okay.
This is Jim Ward, just chiming in by phone. I have to echo what Rick said, because it was actually this group on a group call where I faced this dilemma about where I was going to get my radiation treatment. And once I shared with the group, and I was considering the University of Kansas because that was in my backyard, but once I shared with the group that the radiation oncologist wasn't even going to use the fiducial markers, and there were some other issues with just the way that they would put you on the table and kind of cradle you and keep you from moving, that there was a strong consensus in the group that I shouldn't do it there. And I ended up having it done at MD Anderson in Houston. And I actually went down there and set up an apartment for 2 months. And I feel like it probably made a significant difference. So I have to thank this group for that. It was a pretty important fork in the road, and I think it did turn on the state of the equipment and the state of the technology.
Thank you. Thank you.
I'd like to.
Sorry.
Well, this is John. I just wanted to tell you my wife's criteria for choosing the best radiation oncologist. We were choosing between two guys, and I did end up with a really superb radiation oncologist. But the guy we didn't go with, we had a long session with him, and all during the education process, whenever he talked about the aiming, the dose, anything about the treatment, by way of illustration, he would point to his own crotch. Well, after about an hour of this, my wife was finding it quite disturbing. And so we ended up going with the other guy. So that's one test you could make.
Okay. Yeah.
I think it's a unique case, John. But anyway, yeah, we always recommend people go to NCCN hospitals, comprehensive cancer centers. If you trust your medical oncologist there, listen to their recommendation, talk to people who've gone to that person for radiation, see if they were satisfied. This is not a simple thing to narrow down. It's just got to educate yourself, listen to the guys here in this forum. And what type, is it IMRT radiation you're getting?
Yes, it is actually. Yep. External beam X-ray.
Yep.
And
is this a treatment, or did you have a prostatectomy? I forgot your history.
Yeah, I had a prostatectomy 2 years ago. 2 years ago, and then started having the biochemical recurrence maybe 6 months ago.
Yeah.
And
so
we're working with
even with IMRT, external beam radiation therapy, there are different types, and there's more contemporary IMRT. Some IMRT is more contemporary, or some EBRT is more contemporary, like IMRT is a more contemporary method. And sometimes in the boonies, they're still using very old equipment. Now, I could say to you, you might want to, but it's probably going to be too far. You might want to think about going to Madison, because Madison has a very, very good radiation oncology group. They're actually doing or they were last year doing some trials where they were using stereotactic body radiation for salvage, as opposed to just focusing on the gland. And so they've got, and we know some of the radiation oncologists there, and they're really good. But you know, probably that's taking you right the way across the state, and you know, that's a long way for you. But what I might want to do is talk to the people at Masonic, and ask their radoncs there, do they know anybody in your area? Can they recommend? Or call up University of Wisconsin at Carbone and say, you know, I need radiation. I need somebody in my area. Who would you recommend in the area? I mean, does University of Wisconsin have a local hospital, a local cancer hospital?
I know. The name I've heard here is Joshua Lang. Is that his name down
Yeah, he's
Madison?
really good, but he's not a radiation oncologist. He's a
Oh yeah.
genitourinary medical oncologist, but he's great. But there are people that he works with. I'll tell you in a second. I mean, because I remember. Let me just look up Dennis McGuire isn't on the call today, but let me see the name of his. What was the name of his radiation oncologist? Hold on a second. I'm just looking. But I think, you know, they may be able to recommend somebody to you. Floberg,
Okay.
that's the guy. Floberg, Floberg.
Did
He-
Antennarakis recommend anybody?
Well, he sent me to a fellow at the university, yes, Chin-Soo Cho, CHO, and I did visit with him, and he seemed fine. But again, I just don't know. You know, it's it's a university hospital. It's from a guy who's lived 35 years here in the boonies. You know, it's like you know, parking ramps and just, you know, overwhelming building, and you know, I just feel like kind of like deep in the basement of a huge building. It's like I don't know if this is good or bad if he's, but anyway.
But Cho is in Minneapolis, right?
Correct. Yes, he is. He's
So you know that I think the point there. Look, we can give you comfort over big buildings, we hope, but you've got to go to a reputable place, and most radiation oncology departments are in the basement because they always put Jerry Pelfrey will tell you this. They always put the radiation in the basement because it's the safest place for it to be. So when you're in a big hospital, it's always going to be there. Yeah, if you go down the road to a local guy, but the local guy doesn't have the experience. The question is, who's designing it? It's what we said before. So, and this is so important. And you know, we've seen how these issues around these attitudinal issues and anxiety issues can seriously affect your treatment. And so anything we can do to help you with that, we would love to do. We're here to support you on that, but we encourage you to try and go to a really good hospital, I mean, what's the difference in distance between Minnesota and Madison, between Minneapolis and Madison for you?
about twice as far to Madison, but a little bit more than twice as far, 200 miles from here. But Minneapolis is about 75. But thank you. I really hear what you're saying actually about the anxiety piece. I think that's definitely an ongoing, challenge. Each fork in the road does represent kind of a place for the anxiety to amp up.
So I want to say something about that very quickly, which is that we are working with a company came to us just recently, and they're seeking FDA approval for 4 different applications to help cancer patients. And one of them is specifically to help with anxiety on recurrence. And I'll give a shout out to Dr. John, because he and another guy who doesn't attend are both psychiatrists, and both of them have very generously agreed to underwrite these applications before we create any relationship. But the fact is, we recognize that these mental health issues are enormous and they can get in the way of the treatment. And sadly, and gives me a big lump in my throat, and some of us, that's why Jake isn't with us. That's why Jake isn't with us, because his anxiety was so huge, he didn't get the right treatment and he preferred the alternative. He told us he preferred the alternative than dealing with his anxiety. And the other psychiatrist that we're working with wrote both to John and I, and he said, I wish we would have known this, because there are meds that you can take. There is assistance you can get. And as a support group, what we want to do is try and navigate you in the best possible fashion, so that if you've got comorbidities that are interfering with your best treatment path, we're here for you on that too.
It's sweet. Absolutely. Makes total sense.
Dr. John,
That's
do you want to say something on that? Do you want to say something on this issue?
Well, it is really important. Rick, you brought it up to me actually a whole year ago. I'm now fairly deep into the literature about the topic that we talked about, and ready to start calling up some of the psychologists and psychiatrists that are working on it, or either that or experts in the same area. But it just could never be overemphasized how much our mental states affect the quality of our life. That's for sure. And I'm not saying that only as a psychiatrist, but also I got some quick mental health help, both medication and therapy, when I first got diagnosed and was shaking and fearful all the time. Made an enormous difference. So I'm with you all the way there. Yeah.
Thanks. Yeah.
Thanks, John. So we're and a couple of other quick things. I see that Pat Martin put something in about nutrition when you start your radiation. There are important nutrition issues. When you get closer to that, we'll go into them. And another thing that I always tell people, and I did, is try and walk every day. Try and get some exercise every day, especially when you're doing 25 or 30 treatments, because at the back end, you get a lot of fatigue. And if you can exercise every single day, it minimizes that fatigue.
Okay. I believe that for sure. Yeah.
Chuck, just before we move on, I just want to also recommend have a discussion with the radiologist, whenever you choose one, about hypofractionated IMRT. It can shorten the number of visits you need to make if you happen to be traveling long distances. 33 sessions for salvage sounds like full fractionation, meaning they're not trying to cut down on the number of sessions. So with hypo fractionation, they give you a slightly larger dose, fewer radiation sessions. So just talk to them about that.
All right. Thank you. I'll do that.
Okay, thank you.
Thanks very much.
Yeah, really the bottom line is your total dose.
Yeah.
Okay.
Larry Meadows, can we test to see if we can hear you?
We were getting feedback. Let me turn him back on. And he is on. Larry,
I think
you and I know we spoke. I remember we
yes.
spoke.
Yes, you're correct.
Rick, maybe it'd be faster if you gave us a quick wrap up of Larry up to this point and then let him go.
I can do that. Larry, did we have a Zoom go-to meeting session, or did we speak on the phone? Remind me, but I definitely remember we spoke.
Yeah, you communicated with me one time via email. I'm not sure it was phone or not. I think it was email. You kind of followed up on information of the 2 times that I was with you on AnCan back in October, maybe in November. And with your recommendation, I have found I went to Mayo Clinic, and Dr. Bryce was booked too far out. And so I chose Dr. Cassandra Moore. And so my first meeting with her was in December.
Okay, so I'll summarize, but I thought you'd be, I think been in the group before. So Larry, and correct me if I'm wrong on this, Larry 78, diagnosed 2010 with 3+4, PSA of 5.6, but he was T3. He did a radical prostatectomy and had seminal vesicle invasion. That's why he was T3. And when he spoke to us, he was still seeing a urologist through recurrence. He had some recurrence in 2012. Almeida saw some lymph node involvement in 2014 and did some spot RT, or somebody did spot RT. 2018, the PSA was up to 2.5. And I think he must have spoken to us last March. PSA was 7.2. He did another C11 at Mayo. And we suggested that he go see we suggested either Dr. Bryce, Dr. Singh, or Dr. Moore. So that brings us up to December. And tell us how your PSA is, how you like Dr. Moore, and what treatment you're doing.
Okay, thank you. Good report. I did have in mid-November an F18 PSMA scan done at a local institution. And again, that study found no problem. So then when I went to see Dr. Moore, she reviewed it and it was in agreement that she saw nothing, but she would have one of their radiologists examine it too. And his report was the same. So I recently went back to her follow-up appointment, and now my PSA is 17.1. It's doubling time is at a point then where they're recommending that I will probably have, let's see, what's it called? Well, anyway, other meds. She also did a CAT scan last week, and they found a suspicious area, a lymph node, that they could go back and see from other PET scans that it has enlarged. It's doubled in the last 8 months. So I'm now scheduled next week to have a needle biopsy done. And if in fact it's cancerous, then they will do radiation therapy. Also, back in December, she sent some blood sample to Guardant. And the report from that was that there was an unusual appearance in one of the genes, which she said is a gene that is associated with prostate cancer. So, and she also researched and said that about 95% of those guys proven to have prostate cancer, show positive on the F18 PSMA scans, but 5% don't. So I must be among the 5%. And maybe that's an indicator from that one gene that has an unusual appearance to it. Time will tell. Science will dig into that, maybe.
But
Did she tell you the name of the gene?
No. I'll be able to find out if it's findable.
Go ahead, Rick. I think you were talking.
No, a couple of things. The 18F PSMA scan, was that a Pylarify scan? Does Pylarify sound familiar to you, Larry?
Well, they didn't use the term Pylarify. What difference is it between that and the F18 PSA scan? PSMA.
Okay. Well, the only F18 PSMA scan I can think of is the Pylarify.
Okay.
The other PSMA doesn't use F18. It could have been an F18 Axumin scan, which is not.
No, it was not. Definitely, it was a PSMA scan.
Okay, then it must have been Pylarify. Well, maybe the reason why, and I think she's a little off with respect, Dr. Moore, the reason why you didn't show is because you're not what's called PSMA avid. You don't make PSMA if nothing showed. And that the number that we've heard is about 20% of men don't make PSMA.
Oh.
So, and what I would suggest is going back to her and asking for an Axumin scan, because Axumin doesn't rely on PSMA. And if it were me and I had a guy do a PSMA scan and nothing showed, then rather than doing the FDG or whatever it was, CT scan she did this week, I would look for an Axumin scan, because that might show something up. Let me ask my experts here. Does the Brains Trust want to
I agree.
chime in on that?
Well, I think an FDG PET scan would tell you something, Rick.
As much as an
I did.
Axumin scan? Hold on a minute, Larry.
FTG or flucyclovine, Axumin, either one.
Would the Axumin tell you more than the FDG?
I don't think so at this point.
Yeah.
I might
Even with a
mention
PSA of 17?
The FDG that's the one that utilizes radioactive glucose. So you'd have to have a rapidly growing cancer for that to light up, which you might have. His PSA is rising quickly. But, you know, I think the flucyclovine would also pick up whatever he's got, because that's also a metabolic scan. And so actively growing cancer cells are going to pick up the, it's a radioactive synthetic amino acid. So either one would be good. Might be easier to do the flucyclovine than the FDG. I'm not sure.
I did have an F18 Axumin scan in November 2018, and it's negative.
And what was your PSA when you did it then, Larry?
It was about only one.
Right.
Yeah, and I think with a PSA, if it were me with a PSA of 17, I'd get an Axumin scan.
Okay.
That's what I would do.
Well, I might mention that they did a bone scan last week also, and it was negative.
Yeah, they're not very sensitive.
Yeah, the other thing I want to mention in this group, because it came up a couple of times and we've spoken about Dr.E in glowing terms, and I cannot tell you why she says this, but she does not have great respect for Gardant. We don't use Gardant that much. We tend to refer people to FMI, Foundation Medicine. She likes either Foundation Medicine or Invitae. Invitae does do somatic testing. I just checked that out today. They didn't used to, but they do now. And the other people are Caris, but for whatever reason, she's not a fan. And next time I speak to her, I'll find out what her issue is around the garden. But that said, Larry, definitely get a copy of that Gardant scan and send it to us, and we can take a look at it too. I mean, you should have a copy of that for your records.
Yes. Okay, I'll do that. Thank you.
And are you still not on any hormone therapy?
Not yet, but with anticipation of starting it after my needle biopsy, then she's prescribed some to me. Oh, my video went blank.
Well,
we're still here.
Okay.
We hear you.
There. Now I got it. Okay.
Oh, anything for us, Larry, that we haven't discussed?
No, I think we're good. I just wanted to kind of get you up to date on my PSA was rapidly rising, and I had the negative scans and the needle biopsy coming up, and following that by hormone therapy, it looks like.
Do you have any
If not
pain
radiation.
anywhere, Larry?
No, I don't.
Okay.
Luckily, I don't.
No, that's great. That's great news. Anybody have anything, anybody in the group have anything that I mean, this is an unusual case, a PSA of 17.1 on recurrence, and we can't quite find out where the cancer is. I mean, we don't hear that too often. Anyone else want to comment on that?
I mean,
And of the
it's obviously there, right?
yeah.
So I think you need to find a reasonably sensitive scan, such as Acumen or FDG, to find it.
Mm-hmm.
And then once you find it, we'll be much better informed about what to do. Now, also the needle biopsy, I think, could also give a lot of information if you see, depending on the pathological report.
Mm-hmm.
Because, and it may pay to send that to a more experienced pathologist, right? Such as
Mm-hmm.
Dr. Epstein at Hopkins.
Okay.
Because if you're not making PSMA, PSA is high, the cells could be abnormal.
Mm-hmm. Mm-hmm.
Larry,
And
just for your information, on the Acumen scan, I don't think Mayo is offering that anymore.
yeah, I doubt it. I had it at another facility here in Phoenix, and
Okay.
of the five PET scans that I've had in the last 6 years or 7 years, only one of them has shown anything, and now that scan is not being done. It's a C11 acetate scan.
Yeah, that was with the wizard Fabio Almeida, I suspect.
Correct.
So,
Yes.
and yeah, I mean, he did find things that other people didn't find with his C11 acetate.
Mm-hmm.
Definitely. So, but I mean, for those of you in the group tonight, and those who are going to listen in, you know, PSMA is great if it works, but it doesn't work, as we hear today, it doesn't work for every person because not everybody is PSMA avid. And this, by the way, is one of the reasons why they do these concordant scans if you're thinking about lutetium. They do a PSMA scan and they do an FDG scan very close in time because they want to make sure that if you're going to get the lutetium, which is a which is a curative treatment. Curative is the wrong word. What's the word I want?
Palliative.
No, it's not palliative. It's a treatment that addresses the cancer. Doesn't matter. It'll come back to me. I'm having a senior moment. But
survival. Extends overall
survival. All right. So they want to make sure that they're concordant, because otherwise, if you take the lutetium and you've got a bunch of cells that don't express PSMA, you're still going to have the cancer at the end of the day.
Mm-hmm.
Patient selection screening. Maybe that's what you're thinking of, Rick. Anyway, we got to move on, guys.
Okay, thank you.
Okay, thank you, Larry. Let's go to Carl Forman.
Okay. I just wanted to briefly say, as you know, I appreciate Kevin being on the call. I had recommended him to this phenomenal group, and it's glad to have him participate. And I expect that he will be participating more frequent in the future, because there's a great amount of information that comes from here. So Kevin and I started on the same exact day at this potentially breakthrough trial at Weill Cornell, and we both went through 24 weeks. So thereafter, Kevin and I went in somewhat different paths. Kevin continued to use Dr. Tagawa as his oncologist, his main oncologist. He's comfortable with him and his staff. My main oncologist had always been another doctor, the Dr. Soraya at the Cancer Institute in New Jersey. So last Tuesday or last Thursday was my first treatment for chemotherapy, and it was a combination of and will be a combination of cabazitaxel and carboplatin. And that was from a great amount of discussion that was on the site with Rick and Peter and Len. And, you know, I greatly appreciate it. I think I'm on the right track with that combination. Interesting enough, I did ask Dr. Tagawa about that combination, and he said, well, you know, I think you should just go on to docetaxel, which is exactly what Kevin is doing right now, and I think it's helping him. But for me right now, also Kevin was talking about dealing with nausea and other things like that. I have to say that the Cancer Institute provided a whole binder of information for me on day one of the chemo infusion. Very useful and helpful information about all the different side effects, what to do. They put me on or gave me prescriptions for 2 different types of anti-nausea medication. They allowed my wife to be in the room. I had a private room for my first infusion. I won't have that in the future. My schedule is going to be every 3 weeks to have my infusion. I did have updated blood work earlier today, but it was simply a comprehensive metabolic panel. The next PSA will not be until the 9-week mark, when I will have updated scans in addition. So there's going to be a much more comprehensive blood work that will be done at the 9 weeks. And also my next infusion, my wife will not be able to be there. I will be in a treatment room, a large treatment room where they separate people by curtains and whatever. So that's where I'm at. I can say that some of the issues I'm having now, and I think it may or may not be a little too early for me to have any kind of side effects, but I can tell you, like, as of today, my right hand, my fingers have been, for lack of a better word, freezing up when I try to grab something. I don't know if that's neuropathy or if that's something different, but I've been having that, and I've been having constipation issues. I was using Colace, which was really a waste of time for me. And then I switched to Miralax. I've been that on for the past 2 days because I can only take it once a day. It's still a challenge with the constipation. So if anybody has any, I know it was discussed here several times, I think, taking prune juice, but it's kind of disgusting for me anyway.
Well, Metamucil, Carl.
You know, you might want to try Senna Plus, Carl.
Carl, if you use the Miralax, it's not going to work well unless you drink a lot of water, because Miralax pulls water into your colon to loosen things up. So you have to drink a lot of water.
Instead of prune juice, I just buy dried prunes, organic dried prunes, and I eat several of them every day. Works for me, and it's not disgusting.
That's the same I do. I eat 6 or 7 prunes every morning. And by the way, it's good for bone health too.
Oh.
On Star Trek, Lieutenant Worf really loves prune juice, and he said it was the elixir of the gods. And then Whoopi Goldberg just kind of laughed into her bar, thinking about what was going to come next.
Yeah, also, I just wanted to say with the number of cycles that I'm scheduled for, where it's every 3 weeks, and after 9 weeks is the scan and more comprehensive blood work. We didn't really discuss how much in the future this is going to continue. So I assume as long as it's working, it will continue. Correct?
Yeah.
So what was your opening PSA? What was closest as you can tell? What was your PSA when you started chemo?
62.
62. And is there any reason? Is it your preference that you don't get your PSA tested before each chemotherapy session?
That's an excellent question, and you know, I was thinking about that, and I will send an email to Dr. Soraya about that.
So most of the guys that I know and we've experienced here do get measured before each session. That is the norm. Most of them do blood work before each session. I again, if it were me, I would not wait nine weeks
No, I
to
wouldn't
check,
either.
because if something goes amiss, you're not going to see it. I mean, they should be doing CBCs before each session to see how anemic you are and everything else. I mean, this isn't medical advice, but I know that most of the guys do complete blood count before. I mean, let's ask. Look, Cal's nodding his head. John Birch, and
Yes.
Peter.
So
go ahead,
Carl,
guys.
are they giving you Neulasta?
Yes.
Okay.
It's not the shot. It's the one where it's, I don't know, is it like a mini computer where it has a battery, and that exactly 27 hours after the chemo treatment, it has a needle and it infuses me with the medication. And then 2 hours later, I take it off.
Yeah.
I have to correct myself, though. You're right. And I'm looking at the attachments they sent me for the blood work. And yes, they will be doing the PSA and a couple of other additional tests right before the at that mark, at the 3-week mark.
Right. So, I mean, they should be doing a fairly comprehensive blood work before each session. They may not scan you for 9 weeks. That I can see, or even 12 weeks. Some people they go even longer. But definitely, you want your blood work before each session.
Right. I'm actually looking at it now, and the doctor's orders do say CBC, CMP, PSA, MG, FOS, and testosterone.
Okay.
There you go.
Do they give you a port, or are you getting it in your arm?
Nope, I haven't had any issues to date with the arm. And I know, Peter, we've discussed several times, and other people here, that the side effects can be cumulative as time goes on. And then I'm anticipating that once I have the second treatment and the third treatment, I may or not have more severe side effects. So, am I correct?
And make sure the exercise is really huge whilst you're going through chemo, Carl. Really, really huge.
Yeah, and it definitely helps when I talked about that Revital cancer rehab program, and I'm doing that twice a week. So that's also
perfect.
A nice amount of exercise.
Yeah, I mean, make sure, I mean, I'm sure you've told them that you're now going through chemo, and they may make some adjustments, or they may have suggestions for you on how you want to exercise.
Yes. And that's it.
Going ahead with the ice treatment for your extremities, toes, fingers?
Well, you know, we did have an interesting conversation with that, and I spoke to several doctors about that. As far as like the ice cap, there's potentially an issue with, by stunting the chemo from going into the skull, that it can negatively impact any potential cancer cells that move into that area, and to the feet and hands as well. So they did not recommend that I do that.
Okay. Okay, well, good luck, and keep us updated.
And Carl, I would say if your neuropathy gets worse, you need to tell your doc.
Yeah.
Yeah, well, is that why my fingers are not working right now?
Yeah.
Yes.
It is. Okay. Very good.
Don't wait until it gets really bad. You need to tell them ahead of time.
Okay, great. Thank you.
All right, looks like we can go to John Antonucci.
Okay, just quickly about me clinically. Just to remind you, I'm a Gleason 9, 2 years in, and my most recent PSA and testosterone levels are non-detectable. I guess it's income tax time. And my cardiologist scared me with some stuff yesterday, so I'm a little disturbed about that. I just wanted to say. And just some information stuff. I've been looking at the literature on sugar and prostate cancer with the help of Ken Anderson at first. And I came up with no really convincing evidence that sugar is particularly poisonous for us. The only studies that were where it was clearly associated with recurrence or occurrence were with sugar sweetened drinks, which we should definitely avoid, but the correlation didn't hold up with desserts or things like that. And there was also 2 studies against one that fructose levels were particularly associated with prostate cancer. We would be better off avoiding things like saturated and trans fats and making sure we exercise. So we don't have, in my view, we don't have to be particularly strict and very fearful about sugar any more than other lifestyles. Certainly sugar is no good for us. I'm not saying it is. Just wanted to pass on what I've come up with so far.
Very good. Thank you, John. Appreciate that. Any
Welcome.
questions for John? All right, then.
So John, well, so what's going on with your heart?
I had a lot of chest pain in the last year, and the internist thought that it was post-herpetic neuralgia, and the cardiologist thought it was ischemia. I had a positive non-stress test followed by a negative angiogram, and all this beautiful blood flow on the angiogram really reassured me, but there's heavy calcification in a main artery, and the cardiologist explained that difference between the 2 studies by telling me that the heavy calcification is plaster, is lining the walls of the coronary artery going to the heart, allowing full blood flow. But he said that this is also vulnerable to rupture without any warning ahead of time. That would have been caused by the gradual narrowing of the artery and angina. So while I was really happy to have such a nice looking angiogram, now he's got me scared about vulnerability to a more catastrophic event. And I also have a thoracic aortic aneurysm, but it's not big enough to burst or anything in the near future. But he says keep exercising anyway, as much as I can.
I also had a high coronary calcium score, John. What was your score? Do you remember?
It was 350, something like that, and it was all in one artery.
Well, mine was over 700.
Oh.
But he put me on a statin. Are you already taking a statin?
Yes, that's what he said. He said, in the past they used to stent people like us who had a lot of calcium around the artery, but that caused more problems than it helped with, so that the treatment is just exactly what you said. It's aspirin plus statin.
Right. Okay, any other questions before we move on? No.
No, just a reminder that we have to clear this room out at 5 of, because the caregivers are following us tonight.
Rick, do we still have that unidentified caller, or are they gone?
They're gone.
Okay.
Hey, Len, could I ask a follow-up question of John?
Go ahead.
The group. If you're taking a calcium supplement to offset the bone deterioration from prednisone, does that supplement go to the walls of the arteries in your heart?
No.
Yeah,
No,
that's a great question.
It doesn't. The
I
calcification
agree
is
with
really,
Herb about that. That's
the calcification is because you have cells lining your artery, which are taking up cholesterol and then depositing calcified cholesterol along the sides of the artery. Serum calcium or calcium intake doesn't change that.
Okay, thanks.
agree. And we need to take our calcium if we're on ADT.
Yeah, I had not done it, and I'm doing it now.
Let me just slip in to say one thing. I had a calcium score scan done about 5 years ago, and my number was just out of sight. It was 1,880, 1880.
Wow.
And I'm still here.
See, the good thing about this group is no matter how bad things are, somebody has it worse.
Yeah.
It's good for everyone but that guy.
Yeah.
Yeah.
All right.
Yeah, I read the report. The report that anything over 400 is bad, but I couldn't believe mine was 1880.
Presumably,
And it was just a fluke. It was just a fluke that I had that scan because my wife had signed up for it as a result of going to a conference. And I just was going to join her. Well, the day of the scan, she got sick, and I went ahead and had my scan done, thinking I don't need that thing. Crazy,
What did they
crazy
do
high
for
numbers. Well, my cardiologist put me on atorvastatin right away, and he said there's no need to ever repeat the scan because it's not going to change. The atorvastatin will just help it to not get worse. So that's all.
All right, guys, it's getting late and we have more guys to get to. I want to go to Vic.
Yeah, hi. Just a quick update. A week ago Tuesday, I got into the local Center of Excellence to see Dr. Aurora, who was recommended by Rick, and he basically concurred with the treatment protocol I've been getting from the MO I've been seeing, and he offered me a couple tweaks to consider. One of which was to possibly go from 5 milligrams a day of prednisone once a day to twice a day as a tweak. And then the other thing was to possibly switch off of Eligard to Delegrex, I think, for possible coronary issues. And I had talked to my cardiologist about that at some point. I went in to see Dr. Aurora with 4 pages of questions, which he reviewed before he came into the room and went through all of them with me. A great guy, took plenty of time with me, and I liked him. He did kind of give me a better confidence in my medical oncologist I have been seeing, at least for the current stage I'm in. I don't know if the Center of Excellence is going to be able to offer better protocols. If I transition into castration resistance at some point, hopefully I got plenty of time to consider that. But that's the update. The only thing I would question or ask, have a question about is I kind of went in there, the piece 1 protocol, which is ADT plus docetaxel plus Zytiga. If you look right now on the Prostate Cancer Foundation recommendations, docetaxel and Zytiga are still listed as second-line treatments. And yet the piece 1 study, maybe because it comes out of Europe, suggested a first-line treatment. And so that makes me wonder, what are some of the other second line treatments that might be helpful to delaying progression? And how do you find an oncologist who go off label, for that sort of situation? Or is it even something to consider doing?
Who wants to handle that one? Herb?
Are you saying Zytiga without Lupron or another first line ADT?
No, I was just wondering if there are other second line, like docetaxel and Zytiga are both still listed as second line treatments, but because of the.
I think I guess I haven't looked at the guidelines lately, but my understanding from the trials, like Charted and other trials, that both of those are really first line treatments.
And that's exactly what my oncologist said immediately when I first saw him.
And not second line.
Even
Right.
docetaxel?
Yeah. But there has been,
yes.
it wasn't that long ago they were considered second line treatments. So is that correct, or am I incorrect on that?
Well, it depends on your stage of diagnosis. So if you're diagnosed metastatic, it is a first line treatment, depending on the number of mets. If you're not diagnosed metastatic, it's not a first line treatment. So it has to be qualified by your metastatic stage. That's hard to say, metastatic stage. So it really does. It depends on each man. For some men it's first. So for Herb it was a first line, but for other men who are not yet clearly metastatic, say a chick Lindsay, it's not first line. And but your other question is a really good one, which is how do you find a doc who's willing to think outside the box? And this is one of the things we're always looking for here. Traditionally, and is the doc who thinks outside the box respected in the community? Snuffy Myers was the first doc that I came across who thought outside the box, and he wasn't that well respected as centers of excellence, although he did do a fine job for many men. I don't know if we've got any ex-Snuffy men in here. I have to be careful what I say. But he certainly came up with some interesting ideas. The Schultz and the Schultz practice definitely thinks outside the box. I think Dr.E thinks outside the box. That's why I like her so much. But you've got other doctors who are constrained either by their protocol, or if they're in a center of excellence, they're constrained by the trials they're running in their own hospital, which is really sad. We've seen examples of that just recently with two different docs. I won't name names, but we have. And so, when I looked at Aurora's CV, it looked like he was a guy that might think outside the box. So, younger guy, PhD, researcher. So you might want to.
No, he's a great guy.
Good.
He's a great
I'm
guy.
glad you like him. Bind him in. We're not going to get through three guys.
Got to move on to Rick and Vic.
Yeah, we're not going to get through three guys today. We're going to have to do what we did last week and defer somebody to Herb's meeting next week. I'm sorry, guys, but with this weird calendar that we have right now, the caregivers meeting follows, so we just can't go over time, and we've got 5 minutes left to try and get three guys into 5 minutes. So I would say pick who you want to go with, Len, and keep a list of the two guys who don't. And if we don't speak to you this week and you ask for time, please come back next week. You will be a priority in Herb's meeting.
Okay, well, I've got to go with who came on to the meeting first. And amongst the guys who are left, that would be Pat Martin.
I
Go ahead.
defer. I'll put some questions together for next week. I'm good.
Where's my chief muter? Oh, there he is. He got to it before. Okay.
Go ahead, Pat.
Go ahead, Pat.
I'm sorry. No, I'll get some questions together for next time. I'm good.
Okay. All righty. So I've got Tom Swartzel and I've got Tony. Whoever can wrap it up in 5 minutes. Who wants to volunteer? Tom Swartzel or Tony?
I'll go first. Tom Swartzel.
Go ahead, Tom.
It's been a while since I updated everybody. Last August is when I met with my new oncologist. My previous one had left, and I had to pick a new oncologist. So I'm going with Dr. Monk at OSU, the James. And the big question we had was, I'm supposed to have lung mets, and we could never confirm it. So what we decided in August was that I went off my meds. I was taking Eligard and apalutamide. So up until now, I've been off my meds. I have going to schedule a PSMA scan, PET scan, within the next 3 weeks, and then I will see Dr. Monk in 4 weeks. And then at that point, it's going to be like starting over, depending on what they find, where the cancer is located. If there are mets in my lungs or not, we'll either go most likely radiation if I don't have any mets, or I'll go back on another treatment course, which is undefined because we're not exactly sure what's going to happen at that point. So right now we're just waiting for the PET scan. He wanted to wait until my PSA got above 1. Right now it's 1.3, and it's 6 weeks ago was 0.54, so it's going up fairly fast. So I'll be glad when this is PET scan's over with and move on with a new treatment plan. So that's the status I have right now.
Thank you, Tom. Sounds like you've got a plan there. I think we'd all agree it's a good plan. You know, I forgot, we also have Jeff Wood. Jeff, you have something you can tell us in about 2 or 3 minutes?
Yeah, I could probably wrap it up pretty quick. Just over the last 6 months, my PSA, I think I mentioned before, had
Jeff, hold on a second.
Yeah.
I don't want to steamroller over Tom. We've got 2 or 3 minutes. Jeff, we'll add you to the list for next week. Again, I apologize we can't do it, but let's just spend a couple of minutes with Tom. So from what I understand, and this is what we said to you a while back, he's letting your PSA rise to a point where he hopes he'll see something on the PSMA scan. Is that right, Tom?
That's correct.
And what sort of PSMA scan is he going to do?
Clarify.
Okay, great.
Yeah, Ohio State started doing that about before Christmas, November.
Great.
So it's new. It's fairly new.
Right. And when do you hope you're going to do that? You said it at the beginning, but I missed it.
They're scheduling the PSMA scan as of yesterday. I haven't heard anything about that. It's going to take a little while to get through Medicare.
Okay. It shouldn't do because it is all approved. So in other words, what we're seeing, and we've seen this with Len and with Peter and with Dennis Correa, is that intermittent hormone therapy for this time is coming to an end. You're going to go back onto treatment. And then the question is exactly what treatment. We don't quite know yet. Is that a fair summary?
That's correct.
And so my question I was just going to ask the IHT guys, the intermittent hormone therapy guys, anything for Tom to watch out for? And Tom, do you have any questions to ask the guys who have been on intermittent hormone therapy, who are coming off, who have restarted treatment?
Well, I'm only off my meds this one time. I don't know what's going to happen in the future, whether I'm going to still go intermittent or not. After getting off the apalutamide, I wouldn't mind doing intermittent therapy because that was a tough medicine to be on. But who knows what medicine I'll be on, whether it's going to be, they'll go with the docetaxel or, of course, I'll be on Eligard.
Tom, I have something, and then we're going to have to shut up. We're going to have to shut the room down, but something really important. Ask Dr. Monk, tell him you want to do a a technium-99 scan now, okay? And the reason is because you might just be, it might help you get darolutamide.
Okay.
If we see nothing on your scan, and we know that you've been you're on intermittent, we might be able to make the argument that you can get darolutamide. That's kind of what Len did, and because the technium-99 scan is an old-fashioned scan, but it's what they used to define metastatic versus non-metastatic for darolutamide.
Right. Yeah, I remember that from last week.
Right, and maybe you and Len, maybe you and Tom can just exchange some notes on that. Maybe we can coach him a little bit. Maybe we can get him.
Sure.
Okay. All right, thanks.
Guys, I gotta shut the room down. 3 minutes, and we the caretakers are coming in any moment. So I'm so
Tony,
sorry.
I got to say, Tony DeBoss, we're sorry we couldn't get to you. Come back next week, buddy.
Right. I'll take care of you, Tony.
Take him an offer he can't refuse. Sorry.
Right.
Okay, guys. Bye-bye.
Thank you, everybody. Great job, Len, as always.
And the recording.
Take care.
Thank you.